move on with the next presentation. Thank you so much, Mahesh sir.
Thanks, Dr. Jay and the AOC. Thank you.
Thank you.
So I think the next case that I'm presenting is that of a bilateral optic disc pit in a 4-year-old child. So this was a 4-year-old male who came to us with a history of decrease in vision in both eyes since last 1 month. Parents had noticed it 1 month ago. And on examination, his vision in the right eye was 2/60, left eye was 6/24. And the child, when he came to us, was already on Dorzox for both eyes for last 1 month. So this is the Optos photograph for both the eyes, which shows an extensive retinal detachment in the right eye. So it is not limited to maculopathy, but extending inferiorly almost beyond the equator. And this shows the optic disc pit present in the infratemporal area of the optic disc in the right eye, and similarly in the left eye as well. In the left eye, the retinal detachment was limited to the macula, as usually we have the presentation with optic disc pit. So this is the OCT of the right eye, which shows the deep pit here. In some, it's not very clear, but probably a communication was present in this area. And this is showing the extent of retinal detachment. So you can see the line is passing in the OCT. The scan is much inferior to the disc, and the retinal detachment is still present. And here up to the equator, you see subretinal fluid is still there. And this is a video OCT, which shows you how the maculopathy with the retinal schisis here. And as the section goes inferiorly, you can see that the retinal detachment is also present inferiorly, much up to the equator almost. So, and this is the left eye, which is more classic, and you can see the communication also between the optic disc pit and there is an optic disc maculopathy. So left eye was kept on Dorzox eye drops while we decided to operate the right eye because vision was already very low, and there was an extensive RD as well. And this is the video. I plan to do a 25 gauge partial navitrectomy, and because the RD was extensive, I did pass a peripheral belt buckle also, just in case there's a peripheral break as well, because the extent of RD was quite a bit, but I didn't see any break. And PVD induction definitely was difficult. I tried to do it without IVTA because I thought there is a possibility of subretinal migration, but since it didn't come out so well, so I did inject IVTA. And then under IVTA, the posterior vitreous hyaloid was removed. And then 4-year-old child is not always the easiest thing. So I ended up having an iatrogenic break basal to the disc. But that iatrogenic break actually helped me to remove all the subretinal fluid extensively. And as I removed the subretinal fluid on FG, I also removed some amount of IVTA, which had in this time itself gone. You can see the IVTA crystals moving onto the subretinal space, and I could remove it. After FG, I did some little faint laser to the edge of the optic disc pit as well, so that the communication, which was quite extensive, is not there. And not to leave anything unturned, I used just a little sliver of scleral tissue, and I used it through the 25 gauge opening itself. And I plugged in the pit as well, and then exchanged it with silicone oil. So this was after the surgery, and 6 weeks after surgery, post-operative period, vision maintained at 2/60. The retina in the macular area is well attached, but here you can see there's a localized area of elevation, and I suspect this to be subretinal silicone oil. The left eye was quite all right, and if you see the OCT, the right eye, you can see that this area of macula is actually very fairly attached, and you can see this is the pre-op, and this is very well attached as compared to the pre-op picture, and you can see the tissue plugging into the disc as well, so this is closed as well. And you can see the presence of this glial tissue pre-op, which has been removed very well along with the posterior hyaloid separation in the first surgery. The left eye also responded well to Dorzox. So this is how the decrease in maculopathy was seen following Dorzox. So I took the patient again for surgery, and I made an opening onto this area of elevation to remove the silicone oil. And I had to use active suction to remove this subretinal silicone oil. But that, with the help of active suction, I could remove it through a smaller opening. I didn't have to cut it large to remove the whole oil. So the oil came off quite well. And this I then followed up by doing limited laser photocoagulation to the break. And this was followed by C3F8. First time when I did surgery, I injected oil because of the extensive nature of the retinal detachment. And it was a young child, 4-year-old. So I thought a longer tamponade would be a better idea. But then I ended up having this subretinal silicone oil, which needed resurgery then. So following the second surgery, now the retina is well attached and the optic disc pit is closed and the macula is also attached. So these are a few discussion points which came to my mind, that how early can you take up these cases? 4 years, do you think it's too young? I did a little bit of literature search. The youngest patient is around 9. That is because most of the time the optic disc maculopathy comes around something like 20 to 30 years of age and usually not seen very often. Very few pediatric optic disc pit cases are seen. Maculopathy cases are seen. So, and why such extensive RD was seen in the right eye as compared to the left eye? So would you have used gas instead of oil even in the first surgery? I should have also avoided oil maybe? And whether the right eye with such extensive RD would have settled with Dorzox or not. So should we have done a conservative treatment vis-a-vis a surgical intervention right away in the right eye? Thank you.
Very nice case, ma'am. I was wondering that how was the vision improvement after the surgery?
So vision has been 260, almost presenting was also 260. And this is just a month after the last surgery. So we haven't seen a long-term follow-up. It may improve, but then functional results are not always go hand in hand in cases of optic disc maculopathy. Somehow functionally the children may not, the patients may not improve, but the first step is that surgically we have reattached, and you cannot leave so much of fluid behind also and wait for it to get reabsorbed, because 4-year-old secondary RP changes, if they happen, so you may totally lose that was my concept was going on in my mind when I took up this child. And I told them also that if one eye does well, then only we can touch the other eye, and the other eye luckily is doing well with Dorzox. But this one with such an extensive RD, I wondered if it would have responded to Dorzox alone. And the child was already on Dorzox since last 1 month for both eyes. So I decided to operate.
Yeah, I think doing a surgical intervention somewhere within such an extensive RD with the fear of subretinal gliosis is safer to go in and do. Dr. Ajay, Dr. Mahesh, any thoughts?
Parveen, wonderfully managed, and it's nice seeing all of you on the screen. So I have operated one patient of morning glory at 5 years of age, and another patient of optic disc pitted at 7 years of age, and that was the youngest I have ever touched. I don't do so much of pediatric retina, but yes, I didn't know that literature doesn't have people younger than 9. Why do you think there is a contraindication operating earlier? Do you think there's a reason that you could wait for these patients to get remain the way they are?
No, I think the maculopathy associated with optic disc pits takes a little time to happen. Usually, most of the cases are 20 to 30 years. Usually, the maculopathy doesn't happen very early. In fact, the pathogenesis is supposed to be liquefaction of the vitreous, which causes then communication between the vitreous and the subretinal space is one of the pathogenesis. Though a direct communication with the subarachnoid space and all that is also there, which is why they say Dorzox or oral acetazolamide may help, because it shrinks the intracranial, reduces the intracranial tension. But then it doesn't happen so quickly in the pediatric age group, I think. And if there is no maculopathy, there is no indication for surgery for optic disc pit as such. But only thing which caught me, but most of the time we have seen these cases, but we watch them conservatively, not do surgery, because PVD induction and all those things is a problem. And unless you do a good vitreous separation, these cases may not succeed also. But seeing such an extensive RD, I don't know how or why. Maybe I think the crack or the fissure between the communication of with the disc and the subretinal space was quite significant in the right eye, though it was not very well imaged on OCT. And I think that what I learned in this case was that previously cases, 1 or 2 that I've done, I have used a larger area of scleral tissue that sometimes floats away because it doesn't go in very well. So I used a very tiny tissue this time, and I think it sat inside very nicely.
Yeah,
So, and I did not do ILM peeling here again because very small child. Otherwise, we could, if I had done ILM peeling, you could have used the ILM to stuff the
Yeah.
optic disc bit.
because
I
I
don't know
used
if-
the amniotic membrane graft in those patients, but again, it was a larger graft and it floated away.
Yeah, so I think the smaller tissue, I don't know whether anybody else has, Anand or MPS sir, have you used a scleral tissue?
I have not used a
Please.
scleral tissue, but like one of the patients where it was something like a disc coloboma close to the disc was there. So multiple surgeries, like what you have showed also, and then patient again had landed up with a subretinal silicone oil. Ultimately, I used the gelatin foam actually. So I used stuffed it to the gelatin foam, and subsequent to that, the hole closed and the retina remained attached. So that the coloboma closed and then the retina remained attached. That's what I have used. I have not used the sclera as yet actually. Very nicely done surgery. So these are difficult patients. To induce the PVD can be difficult, and also you always have a concern about using oil and whether it will go into the subarachnoid space or into the brain. So that is one concern which is also there. So plugging the defect with something also probably prevents this from happening.
So I
Yes.
had burnt my hands initially also by doing a morning glory recently done with C3F8, and patient came back with PVR and he lost the eye. So I was worried that if I use C3F8 such a young age.
Yeah. I have done a few cases with scleral plugs. What I feel is with the scleral plug, the resolution of the fluid is much faster than just with an ILM peeling. I mean, I'm in too many cases, but even in the patients who have been reported in literature, I find the resolution is faster if you mechanically plug that. And I agree that it has to be a small sized one rather than a massive one. Also, I don't do the laser. I think you did that largely because you thought there was a fissure there and causing that large RD. But I know, yeah. So that is one thing that one needs to caution against. I would perhaps have done ILM peeling also, but given the extent of that RD, I know why you would have gone in with
So,
silicone oil.
yeah,
So that again, it would have been a tough call to make, but I think perhaps that was the right thing to do.
an infratemporal laser, I thought I was not lasering the papillomacular bundle
Yeah,
also.
I
It was
also
much
couldn't make
safer.
out. Okay,
So
yes,
it was much
yeah,
safer.
yeah. Sure.
And I agree that we published that as well, that the slow resolution after ILM peeling, what Anand was mentioning. I was surprised to see that the fluid just actually disappeared on the macula at such a short interval. So, but I agree with Mahesh sir, and I think we in LVP had a case where the silicone oil went through the pit with one of our partner, but why did you have the concern of gas in a morning glory patient? Because I ended up operating a patient with the gas, but coming from India and seeing the gas PVR, I usually call these patients more frequently. So do you think that gas was the causative factor
I don't
somewhere?
know. No. So
Yeah.
morning glory is again a very tough thing. So the break is within the optic disc pit. So it's practically impossible to really laser it off adequately. So that could have been an open break also, and not just C3F8. But I blamed it on C3F8, you could say. But anything, I mean, without it also, it may have caused. With oil, maybe it would have recurred. It may not have closed funnel. That's the only difference. But I agree with the break itself may have caused it. The break was within the substance of the optic disc, with the anomalous disc. So difficult to close those breaks also.
Absolutely. All right. So I think